So I want to bring you, let's say, through the subject of implantable hearing devices now and future options. Now, when we look on what we have available today, we can be quite lucky because for any kind of hearing loss and also degree or type, we have basically technical solutions. And here in this graph from Cochlear Corporation, you basically can see, read it very easily. That's just the degree of sensory neural hearing loss, and that's the additional conductive component. And you see down here where we have near normal inner ear, the bone conduction implants might serve. If you have more pronounced sensory neural component, then middle ear implants or acoustic implants come into play, including these direct acoustic cochlear implants. And once we are going beyond that, then the cochlear implant or combinations with acoustic stimulation are in the game. Now let's start with bone conduction devices. There's a true development from the Baha screw, as you can see it here, to transcutaneous systems with the Baha Attract, to active systems where you basically implant also an active component, and the one on the market is the Bonebridge. And here you see how that is fixed. It's not only a screw, but that is the transducer itself with a electronics package and also a receiver coil. Now it has to be really placed firm onto the bone with the screws, as you can see here. Transcutaneous transmission of energy and information, and that's what patients, of course, like more than just a screw. Now, you can serve patients who actually have up to 25 to 30 decibel sensory neural hearing loss. All what you hear above it is not true, because not only is the threshold, but you have to look on the dynamic range. And when you speak about a display of speech signal, you need at least 40 decibels dynamic range. That means that these devices have to give a gain up to 70 dB if you have a sensory hearing loss of 30 dB. If somebody tells you you can also serve patients with 50 dB, then the device already should have an output of 90 dB. With bone conduction, the whole head has to shake like that. So it's not possible. I mean, don't believe. So 30 decibels is a fair indication. Now let's go beyond that, and that's then the field where you go closer to the inner ear with your vibratory stimulator. We call them active middle ear implants or acoustic implants, whatever. Just for the explanation, acoustic amplification is a hearing aid. It amplifies sound and basically delivers it here through the outer ear canal. It has to go all the way through the middle ear into the inner ear. The cochlear implant stimulates the nerve directly, electrically, and replaces the hair cells. And in between, there are the mechanical stimulating systems, which basically somewhere on the ossicles or at the interface to the inner ear stimulate mechanically, and that's what we call active middle implants. Now, there are several devices out. That's just what we do in Hanover a year of the cochlear implants and these acoustic implants. Now, there are several of them available. The working horse is a metal vibrant Soundbridge. I will go in detail a bit further. But then you have also others like the MET, former Otologics company, now owned by Cochlear. The fully implantable version is called CARINA, where also the microphone and the battery is implanted. And then there is another version, the Cochlear Codex, I will show it. Now first to the vibrant Soundbridge. That is the easiest to be placed. You see it's just single point fixation. Originally here at the long process of the Incus, you see here the action mode as it should act. It's a magnet that's driven by the AC component, which is given over the coil, and then it moves the whole thing. Now this floating mass transducer can, as you can see here, can be placed nicely through posterior tympanotomy. Here it's on the long process of the Incus. Was originally made with this titanium bracket. When you look on what the patient can hear, you see here an audiogram of patients that can be served with that. That's again what they get. You lift it up into the range where they perceive speech, especially here in this frequency area. The system is quite effective. But you also see in the low frequencies that is not that effective anymore. And so if your hearing loss exceeds something like 40, 45 decibels at 500 hertz, you should be careful with the indication for that system. Now, once you stay in this indication range, the patients do much better. That is the monosyllable word scoring at 65 decibels without the system. That is, with the system, you see there's huge improvement, what you get with that. Now, of course, you can attach it to any kind of structure in the middle ear. The classic one is shown here, but you also can go directly to round window, or you can combine it with TORP or PORP, or even with a Stapes piston. As long as the energy is directed into the inner ear, it will function. Now, as I said, if you have more pronounced hearing loss, then this system is not powerful enough, and you need a 2-point fixation system. Here it's shown the Otologics, or now Cochlear MET middle ear transducer, or the fully implantable version, the CARINA. What it does is basically to use here the mastoid rim for a fixation with this kind of plating, and then you have here the transducer, which goes to the body of the incus. That was the original indication here you see, and then it moves the chain. So you get more gain. You also can serve patients who have more pronounced inner ear component of their either pure sensory neural or mixed hearing loss. There are also other options to couple, as I have shown before. Now, then one step further is going directly into the inner ear. So why should you stay outside, have all these coupling issues, how to fix this kind of transducers on some of the articles might be difficult, as you know, from middle ear surgery. And therefore it was, so to say, the concept to go directly into the inner ear, and that's done with this direct acoustic cochlear implant. What it does is basically you use a Stapes piston that goes through the foot plate, for instance, in cases of autosclerosis, and then this piston is attached here to this transducer. It's also mounted at the rim of the mastoid, as we have seen before, and this transducer then has an artificial incus, which you can see here. On this incus now you place then a prosthesis. You see here it's done through the posterior tympanotomy. You also can do, of course, the opening through the ear canal, and then you see this prosthesis is basically brought here on this artificial incus. You can crimp it, and then you have direct sound transmission, so to say, into the inner ear. Now that's also possible to be done on the round window, as you can see here, the round window membrane. Here then this transducer goes directly on the membrane. You see here the cone beam CT scan showing that nicely. Now what do they hear? Well, it's astonishing what you can get. Just here an example, that's the threshold of the patients, the mixed hearing loss, that is the bone conduction. It basically doesn't change much with this procedure. You have the Carhart effect somewhere here. Looking on the gain the patient gets, that is an unaided threshold. That's what they get with a hearing aid, conventional one, and that's what they get with the system. Now, very high up across all frequencies, so there is no limitation in whatsoever the power, and nor in the frequency range. And when you look on the individual data the patients have, the blue bar is always what they had with a hearing aid, and the green is what they have with the system. So several of these patients had zero scoring with the hearing aid, but once they had the system, you see, they really come up, and that's astonishing when you have some patients zero scoring before, and afterwards they go up to 80%. So it's really astonishing what you can get. Here is another display, pre-op word recognition score, post-op, you see more or less they all are here in this field. So it seems to be very powerful to do that, especially in patients where you have this mixed hearing loss. You can't help them with surgery, there's no improvements, whatever, possible with classic microsurgery or with a hearing aid. Hearing aid is not powerful enough. So then these are solutions for those patients. Now looking on indication ranges, we would basically say the Baha is somewhere up here, then the vibrant Soundbridge is in this range. If you need more power, then you see the MET is in here. And if you need unlimited, then you basically can go with the Codax. Now, of course, there is a limitation given by the number of hair cells. And you can, of course, stimulate very powerful the inner ear. If you have no hair cells there, then basically that doesn't function. And of course, there is a limitation. Now, looking on the data we have with this DACI device, which goes directly into inner ear, you see here HSM sentence test, that is something SBO or so what you use, and you see the green dots here are giving the results for these DACs, and the triangles giving the results for cochlear implant. Now you see as long as you are with your inner ear loss somewhat below 65 or 70 decibels, then the mechanical stimulation still is quite good. If you go higher up, then the cochlear implant is much more powerful. So we would say somewhere between 70, 75 decibels, there is a principal limitation for good performance with mechanical stimulation, and then it's, of course, better to go with a cochlear implant. Okay, now what's the future? Well, some people speak about light to stimulate the inner ear. It's not that you stimulate your neurons, but the light pulse, so to say, is converted into a mechanical pulse, and you could think about using laser fibers that are going into the inner ear, stimulating the remnant hair cells, whatever. There's something which might come. Some experimental work is done on that, but it's not really available. Now let's go to cochlear implant. The cochlear implant is basically, as you know, a system that replaces the function of the inner hair cells, and it does in principle the same what the hair cells do, taking sound, transforming it into electrical pulses, which then stimulates the auditory nerve, and then this artificial stimulation, so to say, is then processed by the brain, and you can hear. Now, here you see an example for one of these contact stimulating part of the auditory nerve. The systems also try to mimic the tonotopic organization of the inner ear. High frequencies are displayed here, middle frequencies here, and low frequencies to the apex. So that's what they basically do. And these systems are very successful, as you can see. So far, approximately 500,000 patients have been implanted worldwide. Now, starting at around 1980 until today, we can say that most patients can understand speech, even in noise. They can use a telephone, and that's something which was not present initially. Now, look on these results in a speech test. You see 1981, it's something like 10% was understood by the patient. And in 2003, we already had a ceiling. Today, they even do better in special conditions, as I said. And the main reason why this was achieved is the micro technology, and especially the microelectronics. So what you have in your iPhone today, compared to let's say a mobile phone in 1980, where you had to use a suitcase to carry on, shows it very, very effectively what happened. And that's the same is true here. So the speed of stimulation has increased tremendously, developing many more pulses per second. And then that's, I think, the secret behind it. Now, with these better results, also indications have widened. And initially, these were deaf patients, deaf adult patients. Then we went to children, and then the age for children came down to, let's say, as close as 1 year or 6 months, whenever you detect that they have a hearing problem. The other widening was then to patients who have still some residual hearing, but they do not as well as they will probably do with a cochlear implant. So to say, patients who have residual hearing and they are below a certain percentage of word recognition scores. Nowadays we speak about 45-50%. That means the patient can't use the telephone, and we give them a cochlear implant, and the probability that he can do it afterwards is very high. We also speak about single-sided deafness. So patient is deaf on one side, on the other side he still has hearing that he can use, and then you can give him a cochlear implant, they can combine it. And then there are some borderline cases, means patients who are right at the indication borders between different devices or hearing aid and cochlear implant and so on. Well, the main prerequisite for a cochlear implant is that the nerve is present, and imaging does a great job, as we can see here with the auditory nerve displayed in this T2 weighted image. Of course, we also can do some functional testing. You see here with the electrical stimulations through a needle on the promontory and getting some EABR responses, but that is more, I would say, for scientific reasons. Normally we don't do it in adults. You can use it as a subjective test, simulate, ask the patient, do you hear something? But we very much rely on imaging nowadays, and if the nerve is present, then I think it's the clear, so to say, indication that this should work. And especially in malformations, that is an issue we should follow. Now, electrode insertion, we should do it as atraumatic as possible. 2 reasons. First, we want to preserve residual hearing, and second is we don't want to damage the inner ear structures because we don't know whether there will be better therapies in the future. So if you give a child nowadays an electrode and you damage the intracochlear structures, and 20 years we can regenerate hair cells, then that's bad for this recipient. And so we should, of course, follow this principle. 2 years are better than 1 year. That also has been proven in several studies. Sound localization, improved hearing and noise, all these issues we have with bilateral hearing are also true for cochlear implantation. Well, that's what we have done in Hanover since 1984. It's a huge patient population, and derived from that, we can say that 70% of adult population have open set speech understanding. That means they can use a telephone and they don't need any other help for speech understanding. Children, when implanted early, they achieve normal auditory and speech development, near normal, we would say. It's enough that they can go to mainstream school in about 70% of cases. The results are mainly influenced by the duration and age of deafness and time of implantation. That's true for adults and children. So for children with congenital deafness, we would say they should be implanted in the first 2 years of life. If earlier, even better. And those who acquire hearing loss, we should also intervene as early as possible to restore the auditory information channel. And bilateral implantation gives additional benefit for sound localization and speech and noise recognition. Now let's go for some special issues, the hearing preservation cochlear implantation. There are many patients out who have this kind of audiogram, where you have a high frequency deafness, still some hearing in the low frequencies, and normally hearing aids don't do very well in those patients because the high frequency information is missing. So now the concept of this hybrid systems for electro-acoustic hearing is that you restore the high frequency hearing, giving them a short electrode or at least enough electrical stimulation to restore this frequency range. And for the low frequencies, you would give them, in addition, a hearing aid, which then can amplify sound in the low frequencies to a sufficient level. Now, the major thing is that we do this surgery atraumatic, as I said, and use special electrodes which are made for that. Here, a hybrid L electrode that's 60 millimeter long. Then there's another electrode which is a bit longer, 20 millimeter or 25. That is the CI 422 or 522 nowadays from Cochlear, but there are also other electrodes from other manufacturers doing the same. What you do is mainly to insert through the round window. You place the electrode, you can fix it here close to the cochlea in, for instance, such a ring, and then it's staying stable inside. Now, what do we get? Well, that's basically from initial study we have done in Hanover and then in Europe, how to read it. Well, you see here basically the pre-op threshold of the patients, and that is a post-operative threshold, and these are individual data points. Ideally, they all should be here on this diagonal. Of course, you get some change. Not all patients have this. Some have, let's say, drop-in threshold of up to 15 decibels, or others are 30 decibels, or even beyond. Beyond would mean they lose their hearing completely. This is partial loss, and if they stay between 0 and 15 dB change, that's kind of preserved. And here you see it more on the median. That is pre-op threshold, that is post-op, and that's the median deviation or difference you have. So it's about 10 decibels they lose with this kind of procedure, mainly because the electrode is in the cochlea. Some of them also lose their hearing, we say 7%, but 93% you can preserve it more or less. And that's, of course, great news. It also stays stable in most of them, these patients. And that means that we can preserve this residual hearing once we follow these rules, and also that we can, so to say, give patients this additional electrical with the acoustic hearing. Acoustic hearing is important because it's more natural. You can listen to music and you have better speech and noise understanding. So that's what it does. Okay, hearing preservation. Today we also can monitor the cochlear function during surgery. We can record cochlear microphonics, and you see if you have a huge drop here in amplitude, that shows you something has happened. So you can then correct your insertion process, can draw back electrode, whatever, and do it like this. Individual anatomy, not all cochlea has the same size. You see here kind of the range in length of the cochlea, something 25 to 36 millimeters from old anatomical studies that is known. So you can perhaps adapt your insertion to this individual anatomy. Okay, the future, well, we might be better if you use some robot or some help from mechanical assistance systems. You see here some work that has been done, Vanderbilt here in the US, some in Europe. The principle is that you use pre-op imaging data, you make a kind of ideal pathway to the cochlea, then you use a kind of drilling guide, and then once you have done this, this canal to the cochlea, you can insert the electrode, so to say, with a mechanical help, and make it even better than you would be able to do it with your hands. Single-sided deafness, that's something which was widely explored in Europe. So what you do is basically to give the patient one implant on the deaf ear, and if you then look on the speech course, speech and noise, you see that once they use in addition the cochlear implant, then they do better than if they would use only their single-sided ear, which still is functioning. So that's the basic. It helps, yes. The question is whether the patient really accepts it or wants to have it, and it depends a lot on their situation overall. So those being in the job, they asking for that. Those having tinnitus also might benefit from tinnitus suppression. Well, what are the main limitations we have in cochlear implants? The main thing is that it's a bad replacement of the inner ear. Bad in the sense that we don't replace some 3,000 hair cells, but we only have something like 22 information channels. So that's a huge reduction. And to overcome it is very difficult. I mean, you can do better electrodes, whatever, but it's not easy. You can imagine the dimensions to manufacturing it, and so it's not that simple. And so how can we do better, for instance, just when we look on the information processing? So if you can only transmit a certain amount of information, let's say normally audio signal, 700 kilobit per second, the cochlear implant can only transfer this. So it's nearly 10%. Okay, now that means not everything goes through, but you can somehow overcome it. And you know MP3, so MP3 is basically exactly doing that. You reduce the whole information to what is important. And this important information only is then transferred. So when you listen to music, you basically would not be able to tell what is the original and what is the MP3 processed. Your ear does not, so to say, perceive it. Your brain does not recognize it. And you need only 10%. That's the compression algorithm, MP3, approximated 10% of the original signal is gone. The reason is masking. The masking means that a previous acoustic stimulus makes the ear insensitive for what is coming for a certain time. And so you can use that. It's a complex algorithm, but it's very efficient. And this MP3, for instance, also has been developed for the cochlear implant. Now, the other thing what we can do is to do better electrodes. One thing would be the electrode should be very close to the nerve. And so how to do that? Well, nowadays, you see there are some preformed electrodes made, but in the future, we probably want to have them really tightly fitting around the modulus, because that is the nearest distance to the nerve. And you see here some experimental work done with hydrogel. The hydrogel, you say, takes water, and once it takes water, it can, so to say, then roll up the electrode, something that might come in the future. The second is, you see here, we have the electrodes here. These are the nerves here, and we have to bridge this gap. Even so the electrode is here, you still have here a distance to bridge. And the one thing you could do is to make the neurons growing with the dendrites growing out onto the electrode, something which you can do with biology, drug therapy, for instance, neurotrophins, some gene therapy that helps to the nerves to regrow, or some stem cells you put into the inner ear together with the electrodes. That's something which is, I think, very close. We will see it in the next years that this will be used. Okay, at the end, just some word on central auditory prosthesis. Now, we use cochlear implants to stimulate the auditory nerve, but this means that the nerve must be somehow present. If that's not the case, some patients have damage by tumors or accident or agenesis of the nerve, then this would not help, would not work. And we have to go to other structures, along the auditory partition. And one is, for instance, that you can go on the brainstem. That would be here, the second order neuron, or even higher up to the midbrain. And you can place electrodes there and stimulate, and patients also might hear. So here you see what is done with the brainstem implant. You go with this electrode. It's a surface electrode that goes on the surface of the cochlear nucleus, and you can stimulate there. And patients also would perceive sound. You see here bilateral tumors, for instance, trauma, following here, ossification of the cochlea, and so on. So you do it just here in a video. What you do is you place this electrode, a so-called lateral recess. That is a suboccipital approach. Patient is lying down. Here you see some nerves, the lower cranial nerves, and then you open this lateral recess where this electrode is then placed. And here, just to show you, that's how the electrode is then brought into this recess, and then the patients, so to say, can hear with it. Now, the point is that the hearing is much poorer than with a cochlear implant. When you look here, that's what patients with cochlear implant can get in a certain speech test. You see here up to that performance. That is auditory only. And with the brainstem implant, the patients might be that good, but only if they combine hearing and lip reading. So you see, it's much worse than what you basically would have with a cochlear implant. And that's through the fact that we are already higher up in the processing channel. So the brain already has done something, and we so far have not understood how that is really done. There are other options going higher up to the midbrain that also has been done. So to say, to place electrodes into the inferior colliculus. Here one example in a clinical study just showing you, it's like a peaking. You have a penetrating electrode. The neurosurgeon makes a dissection here from behind. It's above the cerebellum, and you can reach here the surface of the midbrain, and then you identify the inferior colliculus, and then an electrode is placed into it. So just in the next seconds you will see how that is done. So now it's opened, and you see here now the electrode is so to say brought in, and it stays like a spare in the brain. Okay, well, at the end, a few words to what we do in Hanover. You see, we have a big center there. It's dedicated to hearing. That's started in 1984, first cochlear implant. Then we have several other steps like Children's Implant Center, German Hearing Center, where all patients with hearing loss are treated. We have some collaborative research grants, a Center of Excellence for Hearing Research, huge undertaking. Then we have some institutions for hearing research, and also then Fraunhofer, where we, together with companies, go for new products. And that's all done in a kind of development chain. You see here, that's what we have here. There are people behind it, those who do it. You see a few names here, co-workers of mine who do it, and they all are involved in this kind of work we have done since 1993, when I did take over the department chair. Okay, thank you for your attention.